Okay, we want to see the various central nervous system lesions. These lesions, that means the sectioning of various levels, and these were done in cats. Usually, these experiments were done in cats, and the whatever they manifested, they would be taken and compared with the human disease conditions. Now we discuss these CNS lesions. Already we have done with the spinal animals where spinal cord is sectioned. So it is being taught to you in the spinal animal. So like that, either we can go from the bottom. This is the spine. When the spinal cord is cut, that is a spinal animal. All the things below the level, these things is disconnected. Entire thing is disconnected from the spinal cord. Or you cannot do the medulla because the medulla has the vital centers, and that has a that will the animal will not survive, or the man will not survive any medullary lesions. And then you can go little above the pons, upper pontine region, where we have seen the pneumotoxic center and apneustic centers of the respiratory system. So there will be a problem with the respiration. The apneustic breathing may come. This is the low cerebrate region. This is one section. Then comes the classical red one is the mid-collicular section, and then we have the blue one is the high collicular section. And this high collicular section, then we have this green one is the hypothalamus is isolated. Hypothalamus is cut from the rest of the neural connections. Then these dotted lines is the decorticate. So that means we are trying to see today the decorticate, decerebrate, and other preparations. Now, in the most of the CNS functions were understood by studying the animals after cutting those various connections, and how they manifest in different ways. That I will come in the subsequent slides, because I have already given you the slides in the yesterday. The manifestations of these experimental animals were compared with the disease state of the man, and they have examined and they have seen. Previously, we were not having these imaging techniques available. We have to just interpret. Nowadays, we know that we have the CT scans, MRIs, and even the functional MRIs, and all those things are available that we can really try to know which part has gone wrong. Now, so these are some of the animal preparations. I have already briefed you in the first slide. Decorticate animal, wherein this entire cortex, entire cortical mental is separated from the rest of the neural tissue. The midbrain animal is the midbrain is intact, and the remaining part of the cortex is removed. When this midbrain animal is prepared, thalamus and the hypothalamus, they remain intact. And then comes the hindbrain. This is the high decerebrate that forms the midbrain animal, and the mid-collicular sectioning that makes the hindbrain animal. That means this part of the brain remains intact. The pons, medulla, and the cerebellum, they remain intact. The decerebellate animal, where the cerebellum is cut, that is the after doing cerebellectomy, and the spinal animal is this. Okay, so now let us consider what are the things to be studied when you make the preparations. Here I take up the normal individual without any lesion, and in the normal individual, he has the higher functions. What are the higher functions? Higher functions is the memory, learning, and the all other cognitive activities. So he is able to tell the date, time. He is able to speak, and he is able to do small calculations. Those are, and he is able to tell or recall where he studied from or whatever. These are higher functions, and even the social behavior. And this one we all have. This is a normal individual will have, and the integration is at the cerebral cortex, especially the neocortex, the prefrontal cortex, the limbic cortex, and the neocortex. They participate in the higher functions because you need the all the somatosensory areas, the motor association areas, the somatosensory association areas, limbic association areas. They all club together. We will perform that. Then comes the next component, the conditioned reflexes. The conditioned reflexes are those reflexes which are established after, because they are not there in the beginning, but these reflexes get established in due course of time when we pair the unconditioned reflexes for some conditions. So you already know the ringing of a bell and the presentation of the meat by the Pavlov has led to these conditioning reflexes. So these are called a classical conditioned reflexes. The classical conditioned reflexes, the presence of cerebral cortex is necessary because he has to understand, or the animal has to, or the person has to understand the entire sequences of events. That means ringing of the bell. Ringing of the bell means the sound, it has to go to the auditory cortex. From the auditory cortex it has to be interpreted. So that means a pairing of the sound and the meat, the salivation. So those things are to be done. So this is called a classical conditions. There is another condition, maybe I will just name it, I may come it when I talk about learning and memory. There is an operant conditioning. Operant conditioning, that means operational. These operant conditionings, that means this is a award and a reward and a punishment. So suppose you do this, I give this, something like that. The whatever the human beings, okay, you are also having a operant conditioning now because you are doing the MBBS course, because you want to condition yourself to be a doctor. So that is the reward you are going to get. So these animals also, where if an animal performs a particular action, so he will be rewarded with a food or whatever. So now even these operant conditions are maybe positive or negative. Positive annotations is the enjoyment, or a punishment. Punishment means if he does not do the work, he will get the punishment. That is why he does the work. So these are operant conditions. So I mentioned about the classical conditions of Pavlov and operant conditions of a Skinner. Skinner performed the operant conditions. Those are operational conditions. So anyway, they are present, and for this you require the presence of neocortex, because you require a large number of neural areas. Then emotional reflexes. I am just made a graph here. This is emotional reflexes. These emotional reflexes are associated with the limbic system, the prefrontal cortex, amygdala, and hypothalamus. So now these all we just rejoice, angry, or happy, unhappy, sad, all those responses are the associated with the limbic system, hypothalamus, prefrontal cortex, and amygdala. So that is the emotional reflexes. So these are the integrating centers. Then locomotor reflexes. The locomotor reflexes have three different levels of control. The one level of control is the spinal pattern generators. That means we have the antagonist and agonist group of muscles working. That's the spinal pattern generator. So then we have the same thing. We have midbrain pattern generators. Then we have the pattern generators in the thalamus, and we have a pattern generators in the cortex. But even without cortex, the locomotor activity would continue, or it will happen. So that means the thalamus and midbrain will have the center for the locomotor Writing reflexes, I mentioned about in the last class, the writing reflexes. These are centered in the midbrain, excepting for the optic writing reflex, where it is located in the occipital cortex. Then anti-gravity reflexes, these are located in the reticular activating system of the medulla. So that means they will exert the action on the anti-gravity muscles that try to control. These are mostly the extensor group of muscles. They try to make the body as a pillar or trying to hold on to the gravity. So this is the center is in the medulla. So then respiration, we have the center in the, again, you know the respiratory centers, the pneumotaxic center, apneustic center, the inspiratory center or expiratory centers, which were mentioned classically much before. So now those are there in the pontomedullary junction. It's not only medulla, it's also some part of the pons. Then the spinal reflexes, that is a maintenance of the muscle tone. So these are all established in the spinal cord. This is a normal individuals. These levels we test after doing certain sectioning. Okay, now we come back here. So now this is what the decorticate preparation. So now I have added a decorticate here, and in this decorticate preparations, suppose what is the decortication is? Decortication is a stripping of the entire cortical mantle, the hard, the difficult thing, and you just peel the entire cortex, just like you are peeling one layer of the onion. So now you peel the entire cortical mantle, and then you see that animal is decorticated. So that is, there is no cortex at all. So that type of situation, yes, you may ask me, sir, can it happen in human beings? Yes, it does happen. Suppose if a person is becoming anoxic because of any other conditions, due to any other diseased conditions, he becomes anoxic. Once he becomes anoxic, the cortical cells, they suffer the lack of oxygen. And because of the lack of oxygen, all the cortical cells die. And then that may produce a situation of decortication. The second aspect I will tell about the cutting of the some of the fibers, because you know the internal capsule where all the cortical fibers enter in. If there is a hemorrhage or a hemorrhage in the internal capsule area, so that may also produce decortication. But here the decortication is limited to one side of the body, because it's only happen in one internal capsule. So anoxia, global anoxia produces the global, both the cortices, both the hemispheres are having going. So now what happens in these decorticate preparations? The higher functions are absent. I have made it 0 here. 0 here. The conditioned reflexes. Rather, I would say 0. I would emphatically say 0. The minus and the plus is being given by the Genong. It is difficult to establish. He mentions that comment. It is difficult to establish, but I would not take the chance. I would say 0, because you require cerebral cortex for establishing the conditioned reflexes. Now, emotional reflexes. What happens to emotional reflexes? Emotional reflexes, because the cortex, the cerebral cortex, exerts inhibitory or a suppressor effect on the emotions. Because you see, as we have grown in as a child or infant, if hungry, cries. If passing urine, cries. Or something hurts, cries. So that type of responses, these are emotional responses. Now, as we are growing, these emotional responses are suppressed by the cortex to understand the social situation in which we are existing. So that means they are suppressed. Since the suppressor effect is absent, they get exaggerated. The emotional reflexes become exaggerated. They come back. The locomotor reflexes, because the locomotor reflexes were suppressed by the cortex, then now there is no suppression effect, they are exaggerated. So that means these two get exaggerated, and the writing reflexes, they present, they remain, and anti-gravity reflexes, they remain, the respiration and the spinal reflexes, they remain. Now I want to add on, this is what I had taken it from Genong. I want to add on here. So even the writing reflexes, there will be certain changes. There will be certain changes. I may want that some plus or additional features exist in the writing reflexes. Here what happens? Only the optic writing reflexes are lost because in the decorticate preparations, but the remaining midbrain writing reflexes do remain. And anti-gravity reflexes, they are slightly exaggerated because the inhibitory component. I will come back to that. So the respiration is not altered, absolutely. Spinal reflexes may be exaggerated. So this is, I want to add on, I want to change this one plus plus, this one plus plus, and this spinal reflexes plus plus. Okay, so now move on to the next slide. So this is what I mentioned. Cortical mantle is stripped off. In man, anoxic encephalopathy, that means the brain disease, encephalitis or anything, or a anesthesia, a person is under anesthesia and he goes into a deep anesthesia, he may go into anoxia because of the respiratory arrest. Or as it happens in case of a Stoke-Adams syndrome, you know, Stoke-Adams syndrome happens in the 3rd degree heart block, in which the blood flow to the heart, blood flow to the brain is hampered. If the blood flow to the brain is hampered, it will go into an anoxic state, or that means no blood is coming, no oxygen is coming. So in that situation, you may get decorticate-like situations. So internal capsule lesions, they will produce hemorrhage in the internal capsule. They will produce only unilateral, one side. These are global. This is unilateral. So what you see rigidity, what is called a decorticate rigidity. So this is one aspect. So now the decorticate rigidity, you see here, the upper limbs are flexed, the lower limbs are extended. You see in the bottom here, you have a bottom figure there. So the person, he is having extension of the limbs and the flexion of the upper extremities. This is because I will come back. This is because certain areas in the, because decorticate, these areas dominate. So this is what I mentioned here, extension of the lower extremities and flexion of the upper extremities. And it is something like a double hemiplegic posture. Hemiplegia is one-sided, and double hemiplegic means if it is a anoxic encephalopathy or something like that. If it is hemiplegia, means it is intercapsular lesions. Now, what happens? This is these are the areas. This minus, these are suppressor areas. These two are suppressor areas. The number one is the whatever the motor area, that is minus, that suppresses the basal ganglia, that checks the basal. This is basal ganglia here, basal ganglia, and that suppresses that. And the basal ganglia is suppressing this is the midbrain, the ponto midbrain mesencephalic reticular system. This is excitatory system, excitatory or a facilitated reticular system. This is number 5. This is this is sending impulses, increased impulses, and this is suppressing that. So this suppresses it here. So suppression, this suppresses, suppression of suppression, that means it releases. So you can just see that it is released. Here are the red nucleus. In addition to this, we have a red nucleus here, and the red nucleus is the one which is producing that the lower extremities extended and upper extremities are flexed, because the red nucleus has a dominance in the upper extremity. Now, you have this 1, 2, 3, 4, 5. I will tell about that. So now this is 4 is the inhibitory reticular system. This is the medullary reticular system which inhibits, and this inhibitory reticular system is again being influenced by the suppressor from the motor cortex, because the decortication is we have taken off this. Now we have cerebellum. This is cerebellum. Here there are 3 units, 1, 2, 3 minus units there. They are all inhibitory to the inhibitory pathway there. So that means they would increase the muscle tone there. They will alter the muscle tone there. They would try to, because and you have, this is a vestibular area. This vestibular area is facilitatory to the spinal cord. This is separate line. You have a separate line, that vestibulospinal tract. So this is the facilitator reticular system, the inhibitor reticular system. So like that, we have 1, 2, 3, 4, 5, 6. I have missed here. I will just add up that 6 is the vestibular system. So 4 is the medullary reticular system. 5 is the 5 is the, sorry about that, how I missed it, that I don't understand. 5 is the reticular facilitatory. 4 is a reticulospinal inhibitory, and 6 is vestibular system. Okay, that makes it. Okay, now I just corrected that, and you have this facilitatory. Okay, facilitatory. Okay, that's great. So now vestibulospinal. So now this, we have these 6 units there. These 6 units they will try to govern. Now what happens? So in humans, decortication removes inhibitory control of the corticorubral pathways. Corticorubral here, the rubral is coming here. This is coming here. This inhibitory component is lost. So this means this basal ganglia. Here is the red nucleus. Next comes, so this is what has happened. So you get this figure in the genong. You get this thing in the genong. So this is what the decortication is, and here is the corticorubral pathway. This is a corticorubral pathway. You can just see that a short neuron. This is cut, and because this is cut, and of course you get all these pathways, inputs coming down to the pons, coming to the medulla, and going down to the spinal motor neurons. They are all lost. So that is a rubrospinal tract is excited by cerebellar inputs. Now the cerebellar input gives the excitatory, and this is cut. One excitatory is lost, and this is rather a suppressor here. This is suppressor here, and this is excitatory here, and it will not be able to balance, and that would increase the spasm. So it is because of the increased rubrospinal activity. Now comes, this is what the decorticate posturing is, what I was trying to talk about, the flexion of the upper extremities, extension of the lower extremities. Here we have this individual. This is a midbrain damage. So above upper midbrain damage, above that. So now you have those flexion of the limbs. You just see that flexion of the limb there, and extension of the lower extremities. I've just placed this thing for comparison purposes. This is a decerebrate preparation, wherein you get this type. Suppose if it is hemiplegia, this side, one side, suppose if it is on the left side, left interocapsular lesion, so the right side will be flexed, this is extended, and this would be normal. This side would be normal. So that is a hemiplegic position, because it is a global, because bilateral, and if it is hemiplegia, the unilateral, one side. Now come back here. Now I want to add, I leave the decortication there, and now come back to the midbrain preparation. The midbrain preparation, in which the level of the lesion is above the midbrain. just above the midbrain. That is above the superior colliculus, where we spare the midbrain. And once we spare the midbrain, so you will lose all the higher functions. I will not enumerate what are those higher functions. So he will not be able to perform the higher functions, and the conditioned reflexes are lost. And emotionally, okay, no emotional responses, because the limbic and hypothalamus are also lost. Sometimes the hypothalamus may remain intact. Then in that case, he may have a very peculiar emotional components. But anyway, emotional responses are lost. The locomotor reflexes, they get exaggerated because these are carrying the inhibitory component. They get exaggerated. Writing reflexes exaggerated. Anti-gravity reflexes plus, because some other this thing, respiration is not altered. The spinal reflexes may be exaggerated. So I feel exaggerated, a sort of upper motor neuron type of lesion, you get the exaggerated. So this is what I have taken it from Genong. I am not altered anything, but anyway, I feel exaggerated with the spinal reflexes. Now let us see what is this midbrain preparation is about. Brainstem is transected above the superior colliculus. How do I show that? So maybe here I have, see, look at that. So this is the component where we have transected. This is the these are the inferior colliculus, superior colliculus, and above that, and this is the brainstem is left with. The entire thing is left with. No. So in this figure, if we want to take, maybe it is coming like this. It is coming like this. Okay. Now come back here. So brainstem is transected above the superior colliculus. So this is also known as a condition known as a cerebral isole. Especially during the persons who are trying to see the sleep studies, he will be in a sort of a deep coma. He will not understand EEG features or features of the sleep are desynchronized. So that means there will be a desynchronized sleep. What is synchronization? During sleep, the fast irregular waves were converted into slow regular wave pattern. That is the sleep. That is synchronized sleep. Now in this situation, in this brainstem situation, there will be a desynchronized sleep pattern. Hello. So now red nucleus, subthalamic nucleus, post hypothalamus are remaining intact in this midbrain, in this midbrain preparation. The unconscious proprioceptive reflex will be present or exaggerated. Writing reflexes are exaggerated. Animals, especially the cats, they can stand and they can walk. These animals can be made to walk, but not in monkeys and in primates. It is not possible, because this particular the standing and walking components are lost in monkeys. So that means higher primates are lost it, but in cats and cats it is possible, but it is difficult. You don't think that it will be as nice as with the cortical intact cortex. So now that is about midbrain preparation. So now these are extra points I had given over the table. So now one condition I have mentioned, cerebral isole. Cerebral isole is the preparation when you make a lesion above the superior colliculus. So that means you have isolated the entire thing, only the midbrain is left with. So that is the meaning. And here this type of preparation is used for sleep studies. He will be in deep coma because he does not understand what is happening around. The next component is just I'm trying to see what happens in human beings midbrain preparations. The inhibitory control of 1 and 2 are lost. 1 and 2, these are lost because it is coming here. It is coming here. The effect of 1 is inhibitory to 2. You can just see that. This would be inhibitory. Suppressing the 2. And if two, and also you look at that here, 4, you can just see here, 4. Both are inhibitory. The effect of 2 is inhibitory to the facilitatory reticulospinal tract. So now this is coming here. Here is the red nucleus. Effect of 2 is the it's facilitatory reticulospinal tract. So that is why you get exaggerated reflexes there. Exaggerated reflexes. So that means inhibition of inhibition. It inhibits, it suppresses this, and then the red nucleus is uncontrolled. But here it is at this point you have those locomotor reflexes present. The centers are present. Now, leaving that component, we come back to the third preparation, decerebrate preparation. So this is a very frequently asked question, and I would take it a little detailed manner. So decerebrate preparation were studied. Maybe as I proceed, you will see that. Here, let us examine the table. Higher functions 0. Already higher functions are 0 in either decorticate, midbrain, or decerebrate, because there is no cortex at all. Conditioned reflexes, I'm putting question mark there, 0, 0, because they require cerebral cortex. The emotions 0 here and also 0. The decerebrate animal do not have the emotions. The locomotor, because the locomotor requires the midbrain. The midbrain is not there. Now midbrain is isolated. Only hindbrain is remaining. Hindbrain is remaining. Hence the locomotor reflexes are lost. Now writing reflexes, they are all lost, because the cortical writing reflexes and the medullary midbrain writing reflexes are lost. The animal is not able to stand by itself, and the only thing that we can make the animal to stand. I will tell about that. I will describe about that in the next this thing. But in the anti-gravity situations, anti-gravity reflexes establish, because all the supportive reactions and the extensor rigidity is there, so they will become a pillar-like. Respiration is not altered. The spinal reflexes are exaggerated. The spinal reflexes are exaggerated. This is what the feature of the decerebrate animal, and we'll go here. So you can just see here what is happening. What is decerebration? Decerebration is cutting the brain stem at the in between the superior colliculus and inferior colliculus. That is a mid-collicular section, this green line, the mid-collicular section. When you cut the brain in the mid-collicular section, so that is one of the classical experiments Sir Charles Sherrington performed maybe 100 years back or 120 years back. And he mentioned a number of other features about these things, and this is called a classical decerebration. When you cut this thing, classical decerebration, this is also known as a Sherringtonian, because done by the Sherringtonian decerebration. So both are same. In these animals, the connections above the superior colliculus are severed. That means totally disconnected. The midbrain and the entire component above is missing. Only the hindbrain remains intact. All the connections of the midbrain, thalamus, and cortex are absent. That's true. In man, such situation, can we have such a situation in man? That is one aspect. Yes, sir, we can have such a situation in a man, what is called a uncal herniation. Uncus is the temporal lobe. The uncal herniation, it may happen when there is increased intracranial pressure, or intracranial tumor, or because of the abscess. So like this, large tumors, or the hemorrhages, stroke, abscesses can push the brain into the tentorium, cerebellar tentorium, and that would come up, and that will produce entire brain will be herniating, and that would be producing a type of a lesion which is similar to decerebration. So now But the main feature of this thing is unless you attend to it, suppose if you are a neurosurgeon, you have to open the brain and you relieve that whatever the extra growth which has come, which has produced. The extra growth means these are tumors, hemorrhage, or stroke, or abscess, whatever is pushing that, you relieve that entire thing. Then you may make him survive. Otherwise, the person will die if you don't attend. So this we will get, but sometimes you may not see him in your hospital, because by that time he reaches his death. Okay, so now this is the classical feature of the after cutting. What the surgeon did, he took the cats, anesthetized them. After anesthetizing them, he identified the inferior colliculus and superior colliculus, and he transected. And after transecting, and he allowed the cats to recover back. Once the cats to recover back, they were made to stand on the table. They were made to stand on the table, and with a great difficulty they can place these cats on the table. That to a caricature. You can just see that caricature there with the opisthetonous position. The dorsum is C-shaped, almost C-shaped. The tail is dorsiflexed. The limbs are hyperextended, and he can just stand. This cat can just stand, made to stand. If something touches it, may fall down. So that is the no writing reflexes. So anti-gravity muscles are they are having a rigid. They become more uh, rigid, and these are anti-gravity muscles. Neck, trunk, and extensor. You can just say neck is this thing. This is one of the features of the in cat. So that means maybe I will describe it here. So if this is man. If we are looking at the man, this man is something like this. So he has the extension of both the limbs. He has extension of both the limbs. The neck is going backwards. That is also extended in the sense dorsiflexion, extended the neck like this, and that's the feature. And if you are looking back, here, so this is what the cat is doing here, and both the limbs are extended. So that type of feature you have in case of decerebrate. But in comparison to that, we have the decorticate preparations. You have the upper extremities flexion, the lower extremities extension. The neck is also a little bit extended, but not as much. You just see that neck in that individual here also. Now going back, so in decerebrate cats, what are the things to be seen? So now limbs hyperextended. I have just put this figure there, hyperextended. Tail and head dorsiflexed. Tail is dorsiflexed. This is also coming here, making a C. And the back concave, extreme hyperextension. The back is becoming a hyperextension. That means becoming a C. And opisthetonous position. That means something like that. Then caricature of standing. So that means just you can make him to stand on four legs without any, because these are act like a pillars. These act like a pillars. Decerebrate rigidity is mostly in the, or is greatly in the anti-gravity muscles. Anti-gravity muscles are the extensor group of muscles. They are having a rigidity. That is the typical feature of the decerebrate cat. You can just see that limbs are hyperextended, tail dorsiflexed. That is making this is a dorsiflex, this is dorsiflex, and this is also the hyperextended and the C-type caricature of standing, and that is with the anti-gravity muscles. Now, the aspect here, what is happening, where we are in this situation. In this situation, we are in A. Here we are in A. The lesion interrupts all input from the cortex, the corticospinal, corticobulbar, and the red nucleus, rubrospinal tract. All these things are interrupted. So this is red nucleus here. This is from the cortex, the spinal and bulbar component, and this is corticospinal, corticobulbar. So all are interrupted. The excitatory and inhibitory reticulospinal pathway. One is excitatory, one is inhibitory. Excitatory is the pontomedullary, inhibitory is the medullary, remain intact. They remain intact. The excitatory reticulospinal pathway leads to hyperactivity of the extensor muscles because they are released from the suppressor effect of the cerebral cortex and from the rete nucleus. That is what the decerebrate rigidity is due to. Now, you have I have given an explanation. This one I have copied it from the guidance. The cause of decerebrate rigidity is blockage of a normally strong input to the medullary reticular nuclei from cerebral cortex, the red nuclei and the basal ganglia. These are three components. Lacking this input, the medullary reticular inhibitory system becomes non-functional. Overactivity of the pontine excitatory system occurs and rigidity develops. That is what the Guyton has explained. So that is so just in one way, the suppressor effect of the cerebral cortex, the red nucleus and the basal ganglia on the pontine excitatory system is missing and it becomes excitatory. That's all. It's a release phenomena. Just in one word, you can just put that. Now, same thing here. So now you are missing this component because it is cut. It is cut somewhere here. You are missing this component, this release phenomena. This would be more excitation. Okay, so now decerebrate is explained on the basis of loss of suppressor activity 1 and 3, 2 to 4, 1 and 3, 1 and 3 to 4, and this should be 1 and 2. Sorry, this is 1 and 2 to 4, 2 to 5. 2 to 5 because 1 and 3 because one part is some part is missing there also in this, and 3 to 6. 3 is inhibiting. This is also having a connection there, vestigial nucleus and vestibular nucleus, that is also missing. Okay, these are some of the observations I have made here. I will just put just to think about that. This component just take it from the previous one. Now let us what Sherrington did. Sherrington did certain experiments further because at that time when Sherrington performed 100 or 120 years back, when he performed the experiments, these were very what I will say, the difficult experiments. The cats were anesthetized for hours together and removing the brain tissue one by one, and it is a very bloody and very destructive type of operations. Okay, so they did that, and immediately after the recovery, so they developed that rigidity. They developed that particular stance in the cat, and he examined the rigidity developed in these decerebrate rigidity could be abolished after the dorsal root is cut. So that means this is mediated through the increased activity arriving at the dorsal root. What is that increasing activity? That increasing activity is coming from the intrafusal fibers. These intrafusal fibers, so why they have the increased activity? Because they will receive the increased gamma motor efferents, because the intrafusal fibers receives the gamma motor neuron activity, and because of the increased gamma traffic, the intrafusal drive is increased, the 1 year discharge is increased, and once you cut the dorsal root, once the discharge is not there, so the reflex, this will be abolished. So that means rigidity is lost. So that is a gamma mediated. So now the second experiment, what Sherrington did is he injected a local anesthetic to the motor nerve, or the nerve supplying the muscle. You know, just I remind you, the local anesthetic is a sodium channel blocker. It blocks the small diameter fibers first, then the large diameter fibers. The gamma motor neurons are the small diameter neurons, and the alpha motor neurons are the large diameter neurons. So the alpha motor neurons are spared, and the gamma motor neurons they are affected. So that means local anesthetic abolished or diminished the activity. So that is again in favor of the gamma motor neuron. Then he treated or he injected the animals with a chloropromazine. This is a chloropromazine is an antipsychotic drug, and here in these things they used it for decrease the gamma motor neuron activity. So that means it decreases the gamma motor activity. And when they treated the animals with the chloropromazine, the galpa motor neuron activity is diminished. And once the galpa motor neuron activity is diminished, so the rigidity was diminished. So that is the 1, 2, 3. Dorsal root, cutting the dorsal root, abolished. Local anesthetic, abolished. Chloropromazine, abolished. So then he said that it is because of the increased gamma motor neuron activity. So then he also did, Sherrington also did a certain other experiment, forcibly flexed the head, and the forcible flexion of the head because of the neck writing reflexes or neck reflexes, tonic neck reflexes, they will increase the rigidity. So that because of the increased gamma activity, they also see that. So that means he checked that and he found the rigidity. And he also stimulated the descending tracts and he found the increased rigidity. And all these things put together, he mentioned that. So the intercollicular sectioning, Sherrington's decerebration is due to the gamma motor neuron, increased gamma motor neuron activity. And that gamma motor neuron activity produces the what is called a decerebrate rigidity. Further, they did experiments with the removal of the vestibular tract, maybe vestibulectomy or vestibular neurectomy did not abolish it. And in these animals, when they removed the vestibulectomy or vestibular nerve cutting, so did not abolish the rigidities. That means nothing to do with the vestibulospinal tract. So now, moving on to the next slide. So now, these are the group of workers in 1930. They were not happy with Sherrington or Sherrington's group performing these most extensive and type. They tried to have that animal care because it was a very destructive and a bloody operation. And they did not like that. They said that why can we devise something less destructive? What they did, they wanted to be the wiser men of the world over the Sherrington. Sherrington got 2 Nobel Prizes. He won 2 Nobel Prizes. You just remember that. So now they wanted to be wiser than him, and they bilaterally ligated the internal carotid artery and a basilar artery. They mentioned carotid artery there, but if you make the carotid artery, it is more devastating. Internal carotid artery, which goes to the brain, that was ligated, bilateral ligation of the internal carotid artery and basilar arteries. That means all the blood going to the brain. That means so the circle of Willis, whatever the circle of Willis, these are the main source of blood supply, and they are being cut. Once they are cut, they wanted to see what happens. So this is called ischemic decerebration. So that means they wanted to destroy the entire part of the brain by obstructing or by decreasing the blood supply. When they did that, these animals, these cats, exhibited features similar to intercollicular preparations. What are those features? Limbs are hyperextended, tail and head dorsiflexed. Yes. The back concave. Yes. They got it. It's much more. This extension was much more than before. The caricature of standing. Yes. They saw that. And they can be made to stand on 4 legs. Yes, as Sherrington did, they were able to make it, and there was a decerebrate rigidity of the anti-gravity muscles, and this rigidity was much more than before, or much more than that seen with the intercollicular degenerations. Okay, they celebrated it, and they were very, very happy. Okay, we did it without much difficulty. Otherwise, Sherrington's work or Sherrington's intercollicular or mid-collicular sectioning is the most difficult and the most destructive type of these things. However, they have to stand with the whatever the experiments the Sherrington performed. They have to show that. So, however, when they observed for other features, so what they found, they opened up the, after that, in the postmortem, they opened up the animal and they saw a necrosis in the anterior part of the cerebellum. The anterior part of the cerebellum was totally necrosed. And okay, why they came to that particular point? Because they could not, maybe I will go to the next slide and I will come back here. So they could not see these features. The rigidity was not abolished after dorsal root sectioning. In case of the intercollicular degeneration, intercollicular rigidity, the dorsal root sectioning abolished the rigidity, did not abolish the local anesthetics, no effect. So it did not diminish the rigidity. Chloropromazine, which blocks the gamma motor neuron activity, did not diminish the rigidity. And forcible flexion of the head did not increase the rigidity. Stimulation of the descending tracts did not increase the rigidity any further. However, vestibulectomy and vestibular neurectomy abolished. So that means they found that the ischemic rigidity is different than the intercollicular decerebration. That means classical decerebration. So what is the difference? What is the difference is this is dependent upon the vestibular system, and the vestibular system directly stimulates the alpha motor neuron. So that means this rigidity is a alpha motor neuron rigidity. So the ischemic rigidity, ischemic decerebrate rigidity is a alpha motor neuron rigidity, whereas that was a gamma motor neuron rigidity. Because of these things, they just get back. They found the necrosis of the cerebellum. And they repeated some experiments. Now they came back with the Sherrington's intercollicular sectioning. And now what they did, they cooled because they found that the anterior part of the cerebellum was necrosed. They cooled the anterior cerebellum, and then they found the features of the ischemic decerebration. So then in these animals, they cut the vestibular neurectomy, they abolished the rigidity. So that means they came to know that it is the anterior cerebellum which is playing the trick, which is being destroyed in ischemic decerebrated. And that has changed from a gamma, because the previous one was a gamma and this one is alpha. Gamma to alpha is changed. So that is what they came back. So now they came back here. So now this is what is happening here. So the same thing, A, extensor rigidity in all limbs. So this is A when this is cut, A plus B, A plus B. B is a dorsal root sectioning. This is dorsal root sectioning. This is the red one is the 1A alpha motor neuron, and it is coming here. This is cut here, and A plus C. What is C? This is C here, the anterior part of cerebellum there. This is cut. So then it is enhanced. It is enhanced because these are excitatory. And A plus C plus B. A plus A, this is cut, plus C plus B. So no relaxation of the decerebrate rigidity, because this is dependent upon another component of the alpha motor neuron. This alpha motor neuron is driving. D, flexion of the upper limb and extension of the lower limb, decorticate posture. D is the section D. Section D is a decorticate rigidity. This is a D. So this is what is given in the Genong. This is what I have taken it from Genong. I have explained them. These are small prints there, and I have explained them. So this is what I was trying to tell about this classical decerebration. Now coming back, this one I have already shown. I am again showing you here because this is a decortication. When you have a person with a hand like this, is a decortication. The person with a hand like this is a decerebration. Let you be, decortication is the red nucleus and other things are intact. Decerebration is only hindbrain intact. Hindbrain intact. Okay. Next, come back. I have now made the differences between a decorticate versus a decerebrate posture. Okay, please. This I have already spared, and I will explain. The level of lesion is subcortical. The decorticate condition is a subcortical or loss of cortical mental. Okay. Now here the intercollicular sectioning. The parts spared, all except the cortex, cerebral cortex. All parts of the brain are remaining intact, excepting cerebral cortex. Only hindbrain is spared. Hindbrain is a pons, medulla, and cerebellum. Posture, upper limb flexed, lower limb extended, both limbs extended. Condition in human beings, that may be cerebral ischemia or anoxia and internal capsule lesions. In case of decerebrate lesions, it is uncal herniation because of the space occupying lesions I have made. Compatibility with life. Here, this person may survive. He may be in a sort of a peculiar situation, but he may survive with the gross deficiencies in various the mental and motor sensory deficiencies, but he may survive because nothing is other things are being worked out. This condition is fatal. He may die unless he is attended. So now what is happening to the conditioned reflexes? Minus, I will put 0 there, plus minus, and they are absent. Emotions, they are exaggerated because the cortex suppresses emotions. They are exaggerated. They are not. They are absent. Locomotor reflexes, exaggerated. They are absent. The writing reflexes, they are present, little bit exaggerated, excepting for the optic writing reflex, because optic writing reflex requires the occipital cortex. They are absent here in the decerebrate condition. Anti-gravity plus plus. I have now here in this slide I have made they are increased, and they are much more increased here. Anti-gravity muscles here. The stretch reflexes, they are 2 plus here. They are exaggerated. They are exaggerated in one additional step there. So these are some of the things. One more thing I missed to write here. Maybe I will write. I will write in front of you only. So then one more column I add, and insert rows below. This is also gamma. Both are gamma mediated. So just I have made it. These are gamma motor neurons. Both are gamma motor neurons. There is no alpha coming up. Okay. So now coming back, moving to the further, we have intercollicular versus ischemic decerebration, because that is again I have made this question comes very often, and that I wanted to discuss. The procedure here, intercollicular sectioning of the by surgery. This is the mid-collicular sectioning. This is ligating bilateral carotid and basilar arteries. That is ischemic decerebration. Type of rigidity, it's gamma motor neuron driven. This is alpha motor neuron driven. Dorsal root sectioning abolishes it. Abolishes it, it did not abolish. Local anesthetic, not. Sorry, this is wrongly typed here. Local anesthetic abolished here. This is not abolished. Not abolished. Okay, so now that is it. And chloropromazine, that's gamma motor neuron activity, which decreases the gamma motor, abolished, and did not abolish. Stimulation of descending tract enhanced, did not enhance. Anterior cerebellectomy or cooling enhanced, did not enhance. Vestibulectomy not abolished, and it abolished here. So these are the differences between the intercollicular versus ischemic decerebration. I have just summarized them for your benefit, and you may not get them as clearly as I had written here. Now I move further. So this is some other thing. He mentioned in the genome, he mentions about the spinal animal. Now, in human situations where spinal cord is injured, the person is conscious. He may be paraplegic. Maybe suppose if I have a lower cervical, if somebody is having a lower cervical lesioning, so that means he may be paraplegic. All the quadriplegia, all the four limbs are paralyzed. The sensory and motor inputs are lost, but the higher the head and the neck are they are spared. So for that reason I have made, he made 0 0 0. If the respiration is 0, person is dead. So these are blank I have kept. So the no responses. They may higher functions. The person with the quadriplegia may talk to you. They may laugh. He may cut the jokes. So on. That is what the higher functions is about. And he may have a salivation if you bring a food. So that is the conditioned reflex. And he may just shout at you why you, as a friend, he expects you at a particular time, and that is the emotional response he shows. And he shows but locomotor activity, though he may have, and he cannot perform. That is one. That is lost. Writing reflexes are lost. So these components I agree. 0 0. Anti-gravity, because he does not have a control over limbs, that is 0. And respiration, yes, respiration is automatic. It is controlled because it is happening because if a spinal lesion is there at a cervical segment, the person will die immediately because the respiratory arrest. So if at all he has to survive, it is below C4. The diaphragm should be spared. So that means that is why I have kept this thing blank. I will just put certain things and I will again supply. So then another preparation is a decerebellate preparation, where the cerebellum is cut. In that situation, when the cerebellum is separated, higher functions remain normal. The conditioned reflexes may remain normal, but the reflexes may have some ataxic or metamorphosed things, and emotional responses maybe exist, they remain, and the locomotor responses are incoordinate or ataxic. Writing reflexes are incoordinate. Anti-gravity reflexes are incoordinate, and the respiration, okay. And the spinal reflex, if you try to elicit, you have a slow contraction and a slow relaxation, a pendular type of response. So this is what happens in case of decerebellate. The animal survives with a compromised the motor activity. So this is what the figure, this is what the table I had taken it from a World Kenang, and just I'm supplying it to you because I have not changed some of the things. Some of the things I have mentioned, I was just trying to mention you about the spinal. In the spinal animal, he only mentioned about this component, the spinal reflexes. But if there is no respiration, then how the animal survives, that is one component one has to worry about, and you forget about that and you just keep the blank. Maybe the locomotor reflexes may be changed. So he cannot perform. Up to these 3 zeros you eliminate. Now come back. Okay, that I have already used, that explained. So now the keywords for your examination: decorticate preparation, decerebrate preparation, intercollicular or Serringtonian or a classical decerebration, ischemic decerebration. There is a spelling mistake there, please check it. Then midbrain preparation, that is just above the superior to the supra collicular sectioning, decerebellectomy. these are some of the preparations. I did not cover the spinal preparation, and the spinal preparation, it requires separate these things. This will be coming with the spinal shock and all other components. Now, next class we will go on to the reticular activating system tomorrow, and then till that time I am not giving you any assignment for this. You just read about these whatever the keywords, read and try to prepare and try to have them in your these things. And these are taken from the whatever the Guyton, Ganong and Samson Wright, applied physiology, and the candles, neuroscience. Okay. I think I have covered extensively about that, and you may see a lot of information from my lecture, rather than you need not wonder here or there to get the information. It should be more than enough to get the information. And any other question or other things, please post them so that I can respond. It's a pleasure.